Hi everyone, this week we are going to be talking about the development of the cranium and the neural tube and spinal cord of the baby. So there's a lot of information that goes into this. The baby brain, as we would all assume, is super important in terms of making sure that all of those structures and everything in there is developing properly. When we get into a lot of abnormalities, trisomies, congenital conditions in a few weeks, we're really going to come back to the appearance of the cranium and all of the contents, and then also the neural tube and spinal cord to evaluate some of those abnormalities. So we'll definitely be coming back to a lot of this information. Would have helped if I put that slide up on there for us to start with. So first we're going to be talking about the bones of our cranium. These bones are called the calvarium. This is typically going to occur pretty early on. Like we know with a lot of ossification, those bony structures and systems are going to develop pretty early. So we're going to see this typically by about week 12. We know that really early on in pregnancy, the baby's heads are always kind of looking a little bit bigger than the rest of their body. And then with the bones themselves, we need to know which bone is which. So when we were talking last week about the presentation of the baby during birth, we were talking about the occiput, right? That bony protuberance right at the back of our head, the base of our skull, that broad bone back there, so not just the bony protuberance, but that entire broad bone is known as the occipital bone. So you may remember some of this from your anatomy class. We then have our frontal bone, which is going to be our forehead, and we have our parietal bones. Those are going to be the bones on the sides of our head. Now, of course, babies are not born with a fully ossified skull, right? Their skull is not fully closed, and that's because they're going to rapidly grow when they're a baby and a child and an adolescent. So we have these soft spots in the baby's head. You may have heard that term before, but these are called our fontanels. We have an anterior fontanelle and we have a smaller posterior fontanelle. If you've ever seen a very newborn baby or a baby that's maybe less than 3 months old and they don't really have a lot of hair going on their skull, you can actually see the pulse of their arteries in their head through that anterior fontanelle. Eli had a pretty large anterior fontanelle, and it was the creepiest thing watching it move while it was pulsating. I knew that that was all normal, but it's still a pretty unnerving thing to see your child's pulse through their skull. So the fontanelle is very important for pediatric development of these babies. Now, talking about the shape of the skull, this is where we get into our cephales. So when we're hearing the term cephaly or cephalic, we're referencing the head for some reason. When we're talking about a skull that is pretty much normal in its proportions, we're going to call that a mesocephalic head. Now, if we have a baby that has an abnormally long, narrow head, that's going to be dolichocephaly or dolichocephalic. And then if we have like a really short, round head, that's going to be brachycephalic. So it's important, again, when we're coming back to some of those abnormalities that affect the baby's skull, we need to be aware of which one is which in terms of brachy versus dolichocephaly. And you can see on our diagram here, mesocephalic, normal proportions right in the middle, dolichocephalic, kind of long, skinny, narrow head, and brachycephaly is when we have that wide, short skull. And of course, there's all like normal degrees of a baby that could have a dolichocephaly head or a brachycephaly head, but when we're getting into those abnormal proportions, that's when we're going to have that clinical diagnosis of those terms. So getting into embryology of the important stuff with the baby's head and their central nervous system. Very primitively, we have our embryonic ectoderm. So that term should be familiar to you from our lecture last module. That is going to be one of those very early on primitive layers that things are going to develop from, that main cluster of cells. So our neural tube, which is going to encompass all of the spinal cord and all of the brain material, is going to come from that ectoderm layer. Now, the most primitive structure that will form from that, so kind of like the initial structure that's going to form from the ectoderm, is going to be our neural tube. and then everything will come off of that neural tube. So the spinal cord will come off of the neural tube, will develop from the neural tube, our brain will develop from the neural tube. And depending on how far along we are in that really embryologic stage, when we're talking about the first few days and weeks of gestation for the baby, our neural tube is going to be undergoing a lot of different things. So if we look at this picture on the right-hand side, we have our neural plate, basically. So that is going to be that first thing that forms from the ectoderm, is our neural plate. Then at a certain point, the neural plate is going to say, well, wait a minute, I kind of want to join up with the other side of this neural plate. So they're going to kind of start to fuse together. And when they're fusing together, the neural plate, it's not going to just like disappear or disintegrate. It's going to protrude down from where that neural plate is joining. So you can see that in that middle step there. Now we have a neural fold, which is going to be the point that is going to close on itself, and then we have the neural groove, which is going to be the protuberance that comes out, kind of this little valley that comes out from that neural plate folding and touching on top of it. Once that fully fuses, we are then going to have a fully encompassed tube, and within that tube we can protect our spinal cord. So hopefully that kind of makes a little bit of sense there. Now, it's important to know that not all locations of the neural plate and groove are going to fuse into the neural tube at the same time. So what does that mean? The spinal cord has the proximal, mid, and distal region to it. We have the cephalic end up at the head, we have the mid region kind of in our middle back, and then we have the lower region, or our caudal end, right at the top of our coccyx, so kind of right at our little buttocks crease. So throughout that entire tube, they're going to fuse at different times. The fold is going to close at different times. So it's going to close cephalically first, so it's going to close, at the mid portion first, and then it will close cephalically, and then it will close caudally. So we're going to fuse that fold together right at the mid region of the tube, and then we're going to fuse up at the top, and then we're going to go back down to the bottom and fuse down to the bottom. Now this is going to be really important when we come back to spinal defects, because we see a lot of spinal defects in the lower portion of the baby's spine, and that's because that fusion that should have happened lastly caudally either didn't fully fuse, or fused too late, or didn't fuse at all. So that's where we're going to see a lot of those spinal abnormalities come into play in that lower region, in that caudal region, because of this process of how the tube should fuse. Okay, so moving into our brainstem. So we're going to kind of start up at the top here, and then we will work our way down into the spine a little bit more. Brain is super important when we are doing anatomy scans. We're spending a lot of time looking at the brain, looking at the head structures of the baby. So keeping it kind of broad here, going back to a little bit of your anatomy, our brain stem, this is where we're going to kind of start, and then we'll get into that actual cerebral tissue. The brain stem is going to be the connection between the brain and the spinal cord. So it's going to kind of be this continuation of our spinal cord as it goes up into our brain. The stem itself, so not the actual cerebral brain tissue, but the stem itself is going to be made up of all of these different regions. All of these different regions have their own purpose in the central nervous system. So we should remember that from anatomy, but we'll kind of briefly touch upon all of this a little bit. The stem itself collectively, so all of these sections put together, is going to be the main kind of responsibility for respiration, heart rate, blood pressure, our reflexes. So all of those kind of primitive movements and functions of our body are going to be controlled by that brain stem. Now, those different regions are going to include the medulla, the pons, the midbrain, the thalamus, and the hypothalamus. Now, we've talked about the thalamus and the hypothalamus a little bit, so that should be pretty familiar in terms of what their regulatory processes usually are. So that is something that you can kind of reference back to. And then moving into our brain parenchyma, so we should know that our term parenchyma parenchyma means functional tissue. We are talking about the cerebral tissue of the actual brain itself. So this is when we have the folding of the cerebral cortex, our kind of standard appearance of what our brain tissue is known to look like. We know that we have gyri and sulcus, so that is the peaks and the valleys of that cerebral tissue, that cerebral parenchymal cortex. A lot of different interchangeable terms there. It's going to serve to also separate brain regions and increase cognitive ability. So basically, if we had like all one type of tissue and it was all smooth, there was no like differentiation between it, we wouldn't have as many complex capabilities as we do as normal functioning human beings. So our brain tissue, it is going to have these separate regions that are pretty much in control or responsible for certain things. Our gyri and our sulcus, this is going to become more echogenic the further in the pregnancy that we go. It's starting to become a lot more complex. It's starting to kind of function a little bit more. It's becoming more prominent. But of course, as we know, with gestational age, those bones are going to get larger and larger and ossify harder and harder. So with that bone ossification, we're going to see shadowing and reverberation. So we're not going to be able to evaluate it as well as we would like to, because although that's when it's functioning the most gestationally, that's when we're getting the most artifact and the most limitation in terms of technology. Next, we need to be aware of our meninges. So kind of just finishing up with our basic anatomy here, our brain tissue or cerebral tissue is going to be protected by several layers of covering. So these layers are known as our meninges. The three layers are going to be our dura mater, our arachnoid layer, and our pia mater. Again, when we come back to some abnormalities, we will touch upon some of these layers here, but it's important to know this on a very basic biologic level. So our dura mater, this is going to be a double layered outer membrane that is going to be continuous with the cranial vault. So this means that this is going to be located furthest away from the brain tissue. So closest to the calvarium and furthest away from the cerebral cortex. Now our arachnoid layer is going to be right in the middle. This is going to be really fibrous, and it's actually going to kind of help to hold everything together, to hold these meninges together, to hold the cerebral cortex to the meninges, and then also to hold the meninges to the skull. So we're getting more fibrous protection and connectivity in our arachnoid layer. And then our pia mater, this is going to be a highly vascular layer that's going to be continuous with the cerebral tissue. So if we look at our diagram here, we have our cerebral tissue right here, nice and beige, and then look at that pia mater, that layer, that turquoise layer that's even like going into all of the sulcus and over the gyri, right? So it's going to be nice and continuous, and it's going to be in direct contact with that cerebral cortex. Okay, so now getting into some of the important structures that are our responsibility in terms of documenting on routine exams. One of the most important brain structures is going to be our falx cerebri. And what this does is it serves as this partition between the right and the left side of our cerebral cortex. So like we said, our cerebral cortex is separated into these different regions, and in these different regions are different responsibilities. The falx cerebri is going to be an actual division that separates the left side of the brain from the right side of the brain. And the division itself is actually going to be dura mater that comes down from the outer portion of the brain and the inner portion of the skull, and it actually comes down into that cerebral cortex to create that separation. This is also known as our interhemispheric fissure or our midline echo. So they like to use it as a registry question to kind of throw you off a little bit. So don't be confused if you hear interhemispheric fissure. We're usually seeing the falx cerebri when we're looking at the cross section of the baby's skull, slightly superior. So of course our dura mater, like we just said, this is continuous with the skull, the inside of the skull, and it comes down into the cerebral cortex. So we would expect to see it higher up, right? Closer towards the top of that skull bone as we come down into that cerebral tissue. Now, if we see the falx cerebri on ultrasound, we can actually confirm that the division of the cerebral tissue has occurred. So there is at least cerebral separation if we're seeing the falx cerebri. On ultrasound, it's going to appear as an echogenic midline linear separation. So pretty straightforward for us. And that is going to be this. I don't want to draw over it because I think the picture is pretty straightforward. That's going to be that nice echogenic line. The TH is indicating the thalamus. So that's going to be the region that we are looking at with this. Once we go over all of these different structures that we see on ultrasound in terms of the baby's head, when we piece it all together, it should make a little bit more sense in terms of landmark when you're looking at that cross-section picture of the baby's head. So next we have the cerebrum, or the cerebral tissue. It's important to not confuse the cerebrum and the cerebral tissue with the cerebellum. They're spelt very similarly, they're pronounced very similarly. So cerebrum and cerebellar tissue are the same thing. And then the cerebellum is a different thing. So a little more confusion to your plate. So the cerebrum, this is going to be the bulk of our brain tissue, right? This is going to be our region of where we have complex mental function. We can interpret our impulses, our voluntary muscular activity. So this is where our brain starts to make complex decisions. It is going to be divided into 5 lobes. We have the parietal, temporal, occipital, frontal, and insula. We don't hear about the insula too often. We tend to focus on the parietal, temporal, occipital, and frontal regions. The hemispheres of the cerebral tissue, or the cerebrum, are going to be by the falx cerebri. And then the falx cerebri is going to sit in the callosal fissure. So hang tight with me here. Follow me along for a second. If we're looking at a coronal view of the baby's head, so you have tissue, brain tissue. Imagine that's like your brain. If you're looking at someone from the back side and you're trying to envision their brain tissue. Now we have between so say this is our right hemisphere and this is our left. We already know that our falx cerebri, which is going to be our dura mater that comes down to divide the right and left hemispheres of the cerebellar tissue. It's going to come down, but it doesn't just like sit between the two, right? So it's going to sit in the callosal fissure. So the callosal fissure is the space between the right and left hemisphere, but the falx cerebri is the membrane separation that sits in the callosal fissure that provides that separation. So hopefully that kind of makes a little bit of sense there. We also have the corpus callosum, which is going to keep the hemispheres connected. So this is going to be our corpus callosum, right? Because if that callosal fissure and that falx cerebri went all the way down, well, then we would just have the right side and the left side of the brain, and the two would never be able to communicate with each other. So the corpus callosum is where that callosal fissure and that falx cerebri kind of end, and it allows for that communication between the right and left hemisphere. Now we also have the sylvian fissure, which is going to be similar to the callosal fissure and the falx cerebri in the sense that it separates hemispheres, but these are just going to be a little separation between the parietal and temporal lobes, so much smaller and much less significant than the callosal fissure and the falx cerebri. And then our insula is going to be located deep within that cerebellar tissue between the sylvian fissure and the corpus callosum. So like we said, our corpus callosum is sitting between the right and left hemisphere so that the two sides can communicate to each other. The sylvian fissure is going to kind of sit along the sides between the parietal and temporal. So then our insula is going to kind of be like right in this region here between the two. So here are all of our main lobes put together of our cerebellar tissue, or cerebrum. We have our frontal lobe towards the front, our occipital lobe towards the back, parietal bones on the top sides, and then temporal lobe right where our temples are on the sides of our head near our ears. Okay, so talking about our corpus callosum, like we just said, it's going to keep the right and left hemispheres of the cerebral tissue connected so that they can communicate with each other. And we can evaluate this on ultrasound, and we should evaluate this on ultrasound if it is clinically indicated. Not necessarily part of a routine anatomy scan, but if we're questioning some sort of brain abnormality, we want to be doing a deeper dive. If we're coming at this from a sagittal approach, which is what this picture is, we're going to be able to see it best. So we should be seeing a linear band right in the middle portion of that baby's head. So this is going to be our corpus callosum right here, not the anechoic fluid, which we will talk about in a second, but the band sitting around it. Transverse, we're really not going to be able to fully evaluate that corpus callosum as well as we would sagittally. Moving into our ventricular system. So how do things move within the brain? How do we get fluid to travel through the brain? How do we get fluid to travel out of the brain? We do so by the ventricular system. So this is going to be where our cerebral spinal fluid is produced and transported and kind of stored. And we need to have these different little pockets that can help with that function. So we're going to have 2 lateral ventricles. We're going to have a 3rd ventricle, and we're going to have a 4th ventricle. So we in total have 4 ventricles, but 2 of them are considered lateral. Now these are all going to serve important purposes, especially in terms of ultrasound identification, but the easiest by far to identify are going to be our lateral ventricles. So these are going to be part of routine images that we are taking just of those ventricles themselves. The 3rd and the 4th ventricle are going to be necessary when we're talking about specific landmarks for head measurements, which we'll get to a little bit later on. So our ventricular system is going to contain cerebral spinal fluid. This helps to coat the brain and spinal cord and protect it. We have choroid plexus, which sit within both lateral ventricles, and this is actually where the cerebral spinal fluid is going to be produced. So the choroid plexus is responsible for that production. As our hemispheres grow, so as our cerebral tissue grows and gets more complex, the ventricles in the choroid plexus are going to occupy smaller portions of that region of the brain. So what does that mean? That means that early on in the pregnancy, a lot of that cranium is going to look like it's made up of lateral ventricles and choroid plexus. But as that baby grows, as that head gets bigger, as that cerebral tissue gets bigger, the ventricles and the choroid plexus are going to occupy less and less percentage of that space. So what is the pathway of our cerebral spinal fluid through the ventricular system? So like we said, cerebral spinal fluid is going to be produced by the choroid plexus. Choroid plexus is within the lateral ventricles, so that is where we're going to start. Within the lateral ventricles, they're going to say, okay, I want to go to the 3rd ventricle, right? Because lateral ventricles, there's 2, that's the 1st and 2nd ventricle. Now I need to go to the 3rd. So I leave the lateral ventricles through the foramen of Monroe. I enter the 3rd ventricle. And then I'm like, all right, let's go see what the 4th ventricle is all about. So I leave the 3rd ventricle, I travel through the aqueduct of Sylvius, now I'm in the 4th ventricle. Now I'm like, okay, I'm kind of towards like the back bottom of the brain. I feel like I've overstayed my welcome, so like maybe I'm ready to leave. We are going to go into the actual brain tissue, the cerebral tissue, the spinal tissue, the subarachnoid spaces by the interventricular foramen, which is also known as magenta and Luschka. So now we're kind of sitting and we're like free floating in all of the brain tissue. I'm like not in a pocket anymore. I'm not in a ventricle anymore. So from that, I can spread out. I'm going to go to all the cisterns, which are all the cracks and crevices of the cerebral tissue. And I'm going to kind of surround the hemispheres. I'm going to make sure that I reach out everywhere so that I can protect all of this brain tissue and all of this spinal tissue. Once I've done that, then I don't really serve a purpose anymore. So I'm going to get reabsorbed by the venous system of that brain tissue. So kind of straightforward pathway. So we have our 2 views here, our lateral or our sagittal view, and then we have our anterior or our coronal view. So our lateral ventricles, you can see on both pictures, are really large. They're occupying a lot of space. And then if you're looking for your 3rd and your 4th ventricle, our 3rd ventricle, we're going to look at the coronal view here. It's going to be this cute little guy sitting right between the lateral ventricles. I should have used a different color. Let's see right here. So this is going to be our 3rd ventricle here sitting between the 2. And then our 4th ventricle is going to be right here sitting right at the bottom. And see how when it's in the fourth ventricle, it's like right near the spinal cord, it's right near a lot of like the tissue at the back of the brain. So it's going to leave from that region, right? So it's going to leave from right here, all out into that subarachnoid space and all of those cisterns and hemispheric tissue. So what are they going to look like on ultrasound? Like we said, lateral ventricle is going to be nice, big, prominent, easy for us to find, especially early on in the pregnancy. We're going to be able to visualize these ventricles. Everything that we are talking about, unless I specify that it's from the sagittal view, is pretty much going to be from the transverse view. So imagine if you're taking a slice of this baby's head looking down. Okay, so if like you're looking on top of a pie, that's how we're looking at all of these brain structures in these images. So that kind of sounds morbid, like taking a slice of the baby's head. You guys know what I mean. We're looking for the lateral ventricles slightly inferior to when we start seeing white matter cerebral brain tissue. So if we're seeing a lot of cerebral brain tissue, we want to come down a little bit. That's where we're going to be able to identify the level of the lateral ventricles. Now they're going to occupy a smaller portion as that baby grows and develops. They're going to be hyperechoic. They're going to have hyperechoic borders with also a hyperechoic choroid plexus within it. But the ventricular space itself should be anechoic because it is composed of that cerebral spinal fluid. So it should appear nice and anechoic. We also need to make sure that we are doing ventricular measurements. So we want to make sure that we are measuring perpendicular to the long axis of that ventricle. We are having it with the posterior aspect of the calipers at the ventricular wall and cavity. So what does that mean? What does that look like? Our picture over here, so it's going to be best to see this posterior ventricle. Our ventricle itself is right here. Kind of lose it a little bit there with our picture. That's going to be our ventricle. This is our choroid plexus, which isn't the best picture of it, but what we're looking at mainly is this anechoic fluid right towards the front of this baby's head. Now, when we're doing a ventricular measurement, we want to be measuring perpendicular. So we have our ventricle nice and elongated, and we want to be measuring perpendicular, right? And you want to make sure that we are measuring to the wall. We don't want to include the wall. We want to measure to the wall. So next we have our choroid plexus. Beautiful picture of what that choroid plexus should look like. Hyperechoic. Sometimes we see these little cysts in the choroid plexus. They are totally normal and they're usually going to resolve. We expect to see the choroid plexus sitting within the lateral ventricle, but it's going to sit kind of at the superior level of the lateral ventricle. So it's going to kind of hang out like towards the top of the lateral ventricle, and we expect to kind of see it just sitting right in the middle, except for at the frontal horns. So our lateral ventricles are going to kind of do like this point to them at the frontal region. We're not going to see it sitting in that area. So we can see it sitting in the mid region, we can see it sitting in the posterior region. That's all fine. We just don't really want to see that choroid plexus sitting all the way up here at the front. And like we said, choroid plexus along with the lateral ventricle itself is going to appear very prominent in early gestational ages. Next, we have our third ventricle, super small, super hard to identify and isolate independently. This view is coming in from a sagittal view, so we are looking at the baby's head from the side in. It's going to be a midline, a small midline cavity that's going to sit right between the thalamus. So our thalamus is going to be a butterfly-shaped organ, and we'll talk about that in a second. So we're going to see like this tiny, tiny, tiny little teardrop anechoic area right in between the butterfly wings of the thalamus. So this we also know is going to be connected to our lateral ventricles prior to entering the third ventricle, and then going into the fourth ventricle, it's going to leave the third ventricle by the foramen of Monroe. And if we're looking at this sagittal picture here, this is going to be our third ventricle. So lateral ventricles right here, surrounded by that corpus callosum. Okay, and our fourth ventricle, so again, this is something that's going to be super tiny, very hard for us to find. really unless there is some sort of ventricular dilation. So if we're seeing a really prominent, really big fourth ventricle, we need to say, okay, well, there's got to be a blockage somewhere because this ventricle should not be accumulating this much CSF. We need to figure out where this blockage is occurring. Why are we seeing the fourth ventricle so well? So basically, it's kind of like appendicitis. If you don't see it, then everything you can assume is pretty much fine. If we do happen to see it, it should be small, thin, arrowhead shaped, so kind of like triangular in shape. The midline cavity is going to it's going to have it so that it appears to project into the cerebellum. So sometimes we can see it very posterior where the cerebellum is located. We're not commonly going to see this unless we have that dilation or that abnormality. It's going to have echogenic walls, and if we do see it, it should be nice and anechoic with that CSF. Next, we have our cavum septum pellucidum. So we're kind of working our way backwards through the brain here. Cavum septum pellucidum is going to be something that we see sorry about that. So our cavum septum pellucidum, this is going to be kind of another really small anechoic structure that's going to sit kind of in the middle of that brain. I said we're working our way back. We're not working our way back quite yet. When we get to our posterior fossa, that's when we're going to kind of work our way back. So take back what I just said like 90 seconds ago. So our cavum septum pellucidum, really small, fluid-filled structure, anechoic, just like our third ventricle, just like our fourth ventricle, right? So it's going to be very confusing when you're scanning and you're like, wait a minute, I see all of these kind of small anechoic structures sitting kind of in the middle of the baby's brain. But what you need to do is you need to look for your surroundings and be able to identify what those surroundings are to help you figure out, am I looking at the third ventricle? Am I looking at the CSP? Or am I looking at the fourth ventricle that may have some abnormal dilation to it? So this picture is going to be the classic picture that you want for your CSP evaluation. This is not going to be the picture that you necessarily want for your head circumference or your biparietal diameter, which we'll get to in a second, but this is going to be your best view to see your CSP. So it's going to be slightly above and in front of where the third ventricle is, and it's going to kind of sit between the two lateral ventricles. So if you see your two lateral ventricles, you want to be looking in between the two towards the front of the baby's head for that fluid-filled small cystic region. So this picture is not the greatest in terms of evaluation of the lateral ventricles, but if you see on the picture, it says FH and it has two arrows pointing to the sides. That's standing for the frontal horns of the lateral ventricles. So the frontal portion of those lateral ventricles, and then boop, right in between, we have our CSP. Right in front of our thalamus, our butterfly-shaped organ right in the middle, which has our falx cerebri right in the middle. So see how many different structures you can evaluate from just one nicely leveled picture. So CSP can be really challenging, but rely on that thalamus and those lateral ventricles to help you find it. Next, we have our thalamus. This is a processing center that's part of our cerebral cortex. It is also part of our brainstem as well. So this is going to help us coordinate and regulate our functional activity, all of them except for olfaction, which is smell. So interesting enough. It is going to appear as two large ovoid masses. That's kind of the textbook appearance. I like to call it the nice, beautiful butterfly. Kind of is going to look like a thyroid sitting in there, but it's always going to be sitting right in the middle. We are going to see that third ventricle in the mid portion slightly below where the thalamus is, where the level of the thalamus is. And it's going to be a pretty, standard echogenicity in terms of medium to low level echoes. So this picture here is showing our thalamus nicely. We have our thalamus here. That was the posterior. Well, you guys can't see it when I'm drawing it. So this is going to be the posterior aspect of the baby's head. This is going to be the anterior aspect of the baby's head and thalamus. So let me erase that so you guys can see it. And you can kind of use your thalamus to help you indicate which way the baby's head is is pointing, because the rounded edge here, like the rounded point of the thalamus, is going to point towards the front of the baby's head. And then you kind of get like this widened portion back here. That's going to be the back of the baby's head. And then here you have your nice lateral ventricle frontal horn on that side with your beautiful falx cerebri right in the middle. Okay, moving towards the back of the baby's head here. So the back of the baby's head is a very important region. This is known as our posterior fossa, and it is composed of 3 structures: our cerebellum, our fourth ventricle, and our cisterna magna. We also end up doing a nuchal fold measurement in the posterior fossa, but it's not necessarily considered its own structure. So our cerebellum, this is going to be, let's actually move forward because we have our slide on that here. So actually this picture here, this is the baby's head facing one way. So this is the front of the baby's head, and then this is the back of the baby's head. You can tell because our cerebellum is over here. And now the baby's head is flipped on this picture. So this is the back of the baby's head. This is the front of the baby's head. Well, like here would be the front of the baby's head. So our cerebellum, this is going to help with our fine kind of tuning skills. So it's going to help us coordinate our movement, our balance, our posture. It's a structure that's going to be in that posterior fossa, and it actually occupies the majority of space in that fossa. It's going to be located inferior to the cerebrum or the cerebellar tissue. It's going to be above and behind the brain stem. It's going to be posterior to our fourth ventricle. It is going to be divided into 2 hemispheres. So it is kind of thyroid-like in shape, kind of like the thalamus, kind of butterfly in shape. So we have basically like a right cerebellum and a left cerebellum, and then we have a cerebellar vermis, which connects the 2. So that would be like our thyroid isthmus. And then the size and shape of our cerebellum is really going to help us to be able to determine an accurate gestational age and also any sort of abnormalities. So when we learn about some cranial abnormalities and associations, we'll definitely be coming back to our cerebellum. So here is our normal shaped, I don't know, I kind of call it a thyroid. It almost even looks like one of those time things that you turn upside down. So that's going to be our cerebellum there. So here's one hemisphere, here's another hemisphere, and then this region would be our vermis, keeping the 2 connected. Next, we have our cisterna magna. So we're still within that posterior fossa. This is going to be just like a little pocket of fluid that sits back there. It's going to be a CSF that actually hangs out back there. It's going to be located directly posterior to the cerebellum. And the normal appearance of this is going to exclude all spinal defects. So if our cisterna magna measures within the normal range, we can pretty much rule out any sort of spinal abnormality for that baby. So this measurement is very important. You may just be thinking like, oh yeah, it's just like a little pocket of fluid. Well, if it's measuring too big or not enough, then we need to say, okay, something is going on, and then that spinal cord is going to be at risk for some sort of abnormality. If you don't have enough spinal fluid to kind of hang out in your posterior fossa, to go and coat the rest of your brain and protect your spinal cord, then that spinal cord is going to be at risk for abnormality and abnormal development. So our cisterna magna, we are doing one measurement, a width measurement, to see how wide that pocket is. We are measuring right from the posterior aspect of the cerebellum to the inside of where that skull is going to be. So the inside portion of that occipital bone. So if you look right here, we are measuring here to here. And sometimes we'll see like these little membranes. So see those echogenic lines kind of sitting there? Those are just membranes kind of holding that cerebellum to that wall of that posterior fossa behind it to the occipital bone. Next, we have our circle of Willis. Oh, I thought I had another slide on here about the nuchal fold. Oh, I do. Okay, I'm a little bit further down when we get into the measurements. Okay, just wanted to make sure that I wasn't going to forget that. So moving into our circle of Willis, we do not spend time doing vascular evaluation of babies, especially routinely. Even if there is some sort of clinical indication to do a Doppler on a baby or evaluate their blood supply, it's usually going to be by highly specialized technologists. So this is not something that you guys are going to be doing. Even if you end up working in an OB office or hospital prior to graduation, you're probably not going to be doing any of these Dopplers for quite some time. But the circle of Willis, just like any adult human being, we have that as our main vascular communication in our brain. It is going to appear as a triangular pulsatile vascular region. And the only reason that we typically will do evaluation of the circle of Willis is for our MCA. This is our middle cerebral artery. This is something that can be affected and can give us a better idea of IUGR. So if the baby has that intrauterine growth restriction, we can Doppler that MCA to see what that velocity is doing. If that velocity is too high, well, is that baby not getting enough blood supply to the rest of their body? If that velocity is too low, are they not getting enough blood supply to their brain? Is that why something's not growing as much as it should? So we usually only go up to the circle of Willis if we're questioning the MCA for IUGR purposes. Okay, so moving into our evaluation, and mainly how do we take our measurements of the baby's head? What should we be measuring? So we can identify the baby's head differentiated from the body by about week 8. So really early on, we're going to be able to see that kind of bulbous tadpole skull. Structures in the head, we're not going to be able to identify them until closer to 13 weeks. And even then, I think that's a little bit too early. We're usually going to be able to give an accurate diagnosis and evaluation of the head structures closer to 18 weeks. So around 16 to 18 weeks, we're going to be able to see pretty much all of those structures. Now keep in mind that if you are doing an anatomy scan or you're looking at the baby's head at 16 weeks, those lateral ventricles and choroid plexus are going to be super prominent. So you're not really going to be able to see the CSP, the thalamus, the falx cerebri, the posterior fossa with the cisterna magna and the cerebellum. Like, you're not going to be able to see all that because your lateral ventricles and your choroid plexus are going to occupy like 90% of that baby's head space. So we want to be doing our anatomy scans between 18 and kind of like 20, 22 weeks. Next, for our sonographic evaluation, it's really, really important for you to have the correct level prior to taking any measurements. If you are not at the exact level that you should be in the baby's brain, then your measurement is not going to be accurate at all, and the patient is going to have to get called back. So you really don't want to be making that impression on your patient or on your radiologist. In order to get a head circumference and a biparietal diameter, which we'll talk about in a second, you need to demonstrate 4 structures. You need to demonstrate your falx cerebri, your CSP, your thalamus, and your third ventricle. You need to have all of those structures in your picture. You also need to make sure that you do not include any posterior fossa. So all of these structures are located so closely within each other that just the slight tweaking of your hand can bring your view and your levels slightly obliqued. And yeah, you may have your falx, your thalamus, your third ventricle, and your CSP, but if you have any cerebellum in that picture, it's not accurate. They're going to make you go back and do it again. So it's very, very tricky, and it takes a long time, and it can be very frustrating. So make sure you are patient with yourself and that you're learning as much as possible when you're rotating through the OB rotation. Okay, so our biparietal diameter, we said we need to have our falx cerebri, CSP, third ventricle, and thalamus. Thalamus is going to be the easiest thing for you to find. It's going to be your nice butterfly shape right in the middle. With your thalamus, you're going to see your falx cerebri going right through it. Then your CSP is going to come right anterior to it. So towards the front of the baby's head, right between the lateral ventricles, you're going to see your CSP. And then you're going to see in the middle of your thalamus, tiny little third ventricle. That's going to be what you are aiming for. Now, the problem with this picture is that we have our entire posterior fossa in this view. So we have our cerebellum right here and our cisterna magna right here. We can't use that for a picture. Okay, so I'll show you a picture towards the end of the level that we should be at. But this is a nice example just showing you what the thalamus, third, and CSP and falx should look like. Okay, so with our BPD, we are also doing a head circumference at the same exact level. So this is one of those pictures where, like, if you get the perfect level, you get the perfect picture, you freeze it, you take 2 measurements on that one image. Okay, so don't make extra work for yourself. You still need those 4 structures. You still cannot have the posterior fossa in the view. We're still doing 3 measurements of an average, for an average, and we are using the ellipse caliper for our head circumference. Okay, so any round structure that we need to measure, just like the abdomen on the baby, we are doing an ellipse. We are measuring, the only difference between a head circumference and a BPD is that BPD, we're doing 1 anterior to posterior measurement. We are measuring, I kind of like skipped ahead on that, didn't I? We are measuring from the outer cranium to the inner cranium. So if this were an acceptable image, and we were able to do a biparietal diameter on it, we would go from the outer cranium to, imagine that was straight, to the inner. Okay, so here is my inner cranium, and here is my outer cranium. That is super, super important. Measuring from outer to inner. So outer anterior to inner posterior. Head circumference, ellipse measurement. With this, we're taking outer to outer. So we are including the cranium in this head circumference. Next, we can also do, with the same level picture of the BPD and the head circumference, we can do an occipitofrontal diameter. We are not really doing this unless we are questioning some sort of abnormal head shape. So this is where we do a width measurement, so not an AP measurement like a BPD, but we're doing a width measurement from the back of the baby's bone, head bone, occipital bone, to the forehead. So we're doing outer to outer, so we're going from the outer occipital in the back to the outer frontal in the front. Still taking at the same level of the BPD and the head circumference, and we're still going to do 3 measurements for an average if it's indicated for us to do an OFD. Next, we have our cephalic index. This is when our machine is actually going to calculate the percentage of head shape that that baby would fall into. It takes your BPD measurement and your OFD measurement, and it calculates what that baby's head shape would fall into. You don't need to know the specifics of like what would be considered dolical or brachy, but you just need to know that if you are questioning abnormal head shape, that you should be performing an OFD and calculating a cephalic index. Okay, so here is going to be an acceptable picture that you can use for your BPD and your head circumference on an anatomy skim. If you look, I know it's like a grainy picture, it's not the best picture in the world. Here we have the front of the baby's head, back of the baby's head. Here we have our thalamus. Here we have our falx. And here we have our third ventricle. Our CSP, not our third ventricle. Our third ventricle is going to be this tiny guy right there. Okay. And if you look at the back of the baby's head, we don't see any cerebellum. So that's perfect. Okay. Now, if you look at your BPD, it's going outer cranium to inner cranium. And then the head circumference is going outer to outer. Now, of course, you're trying to do like a round measurement on a machine of a human's head. Like, you're not going to get a perfect alignment of your head circumference, especially when you're just learning how to use the ellipse measurement. So if you look over here, like there's a little gap between the cranium right there, and then the caliper that's going around it. And then same thing like over on this side, we're kind of under measuring a little bit of that cranium. That's just the inevitable reality of what it is to try to get a rounded average ellipse measurement of, you know, of a variable human skull. So you're trying to get it as close as possible. Some small little portions may be over measured, some small little portions will be under measured, but you'll see how the techs perform this, and they get it as close to that cranium as possible. And it takes a lot of adjustment and practice for that. So next we have our nuchal fold. Like I was saying before, this is something that is commonly measured when you're doing your posterior fossa pictures. There is going to be, which this is not a picture of a nuchal fold measurement. I just kind of want to put that out there. This is a picture of a nuchal translucency measurement. So we use the nuchal translucency measurement like we talked about earlier on this semester in comparison with the nuchal fold measurement that we are talking about right now. I have been trying to find a good nuchal fold measurement, but there's not a lot of images out there on them, and I can't get any released from limited. So just bear with me. So our nuchal fold, this is going to be a fold of skin that we see at the back of the baby's neck. So of course, we're talking about the back of the baby's neck, we're talking about the posterior fossa. So if we actually go back a few pictures, where was it? Oh, okay, so right here. This would be a nuchal fold measurement. Oop. So that's thickness measurement behind the cisterna magna. So when you're doing your posterior fossa pictures, you're doing a measurement of your cerebellum, a measurement of your cisterna magna, and then a measurement of your nuchal fold. So I am going to see if I can try to find better nuchal fold images, but I just wanted to clarify that that is a picture of a nuchal translucency. So this is talking about measuring the space behind the baby's neck. This is still talking about, the nuchal fold is talking about the portion of skin behind the baby's neck. So two different things, two different types of exams. Nuchal fold is something that can be incorporated into an anatomy scan when you're doing that posterior fossa picture. Nuchal translucency, this has to be done and performed by a technologist who is NT certified. Both of these have variable literature behind them. They have variable requirements behind them. So it's something that you're going to see changing over the next few years if you work in an OB office, and it's something that different radiologists use different criteria. So, usually kind of similar to the nuchal translucency, it's not going to be reliable after a certain gestational age. So the nuchal fold's not going to be reliable after 20 weeks. So if you have a baby coming in for, a checkup and you're doing a growth scan at 30 weeks, are we going to measure the nuchal fold? No. So this is only something that we're performing in that early anatomy scan range. Or if our patient's coming in at 24 weeks because they missed their anatomy scan, are we going to do it? We might do it, but the radiologist isn't going to use that as any sort of indication for anything. And we want to see that fold nice and thin. We don't want to see a super thick nuchal fold, just like we don't want to see a super thick nuchal translucency. Okay. Next, moving into our spine and our spinal cord. So we're usually going to be able to see the spine in a general sense by week 12. And when we're talking about the spine, we're really just kind of talking about ossification. We're not really talking about any of like the spinal contents or like the meninges within the spine. That's something that we're going to evaluate once the baby is born. There's only so much that we can do. Spine is super ossified. So we're not going to be able to look at the inside contents of the baby's spine that well. So usually by about week 16, we can evaluate those ossification centers a little bit more individually and in depth. When we're looking at the spine, we need the baby face down and the spine up towards the mom's belly button. So what have we said up until this point? We've said that we need the baby's heart up, so we need the baby facing up, and then for the profile, we need the baby also facing up. Oh, okay, now when you look at the spine, we need the baby facing down. So it's like, how do we get the baby to follow what we need it to do? Okay, it doesn't happen. So a lot of times you are going to see anatomy scans have to be called back because their baby just will not flip and the baby will not cooperate. So chances are if you're getting beautiful heart views and profile views, you're not getting beautiful spine views unless that baby is doing cartwheels in there. So it's very common to be called back from anatomy scans just because the baby wasn't cooperating positionally. So in a perfect world, our baby is following our directions and commands beautifully. We're going to be able to see 3 echogenic round areas right in that region of the spine, especially when we're looking in transverse. And each of those echogenicities is going to represent an ossification center. So let's talk about what that means. So we have 3 primary ossification centers in each vertebrae of the spine. We have the centrum, and then we have the right and left neural processes. These are going to be kind of like the notches that sit out on the side of our spine, and then that centrum is going to be the bulk of that vertebral body. Our spine itself is going to taper, so meaning it's going to narrow off at the sacrum, so right at our bottom, and then it's actually going to widen at the base of our skull. So our vertebrae are going to represent those changes. Our vertebrae are going to get a little different towards the caudal region where it tapers. It's going to be a little different at the cephalic region where it widens. The spine itself is going to have a railway appearance on ultrasound, which we'll see in a second. And as we said previously, that the lower spine is going to ossify later than the upper spine. And that's because the lower spine is going to fuse last, right? That neural tube is going to fuse last at the sacrum, at the lower spine. So of course, those vertebrae are going to ossify later. It's going to take longer for those vertebrae to ossify. Okay, next we have our scan planes. We have sagittal and axial or transverse. Those are the 2 planes that we have to document the cervical, thoracic, lumbar, and sacral spine in. We're not really looking at the spine coronally unless we're questioning something wrong. So in the sagittal view, that's going to be our railway appearance. It's going to be right here. We can see the vertebral body in the middle. We can see the lateral ossification centers. Down towards the sacrum, we can see where it tapers into the conus medullaris. That's where that spinal cord is going to taper off and basically end. We can evaluate the skin integrity. So that's very important in our sagittal pictures to be showing that border of the skin nice and smoothly, nice and continuous. Because if we're looking at the skin and we see, okay, this is all normal, nice, and then we see boop, well, we got to question something going on with that spinal cord, right? And then in transverse, this is going to be our most important view for spinal defects. Again, we would be able to see if there's any sort of bulging out of that spine, but for the most part, we have our vertebral body here, and then our lateral ossification centers here. And that is going to be it for this PowerPoint. Lots of new information. Next week, we are going to talk about kind of these measurements a little bit more precisely, protocols a little bit more precisely. How can we indicate what position the baby is in? So we're going to be spending a little bit more time talking about the technical skills, doing an anatomy scan, and then we are going to start learning about some of the extrafetal structures. So talking about all of the other pregnancy structures that are important to evaluate that are not part of the baby. So we'll be talking about amniotic fluid, placenta, umbilical cord, cervix, all that good stuff next week. So hopefully with that ultrasound evaluation PowerPoint, it will kind of piece this module and last week's module together a little bit more cohesively.